Okay. Dr. Anil, got Hi, good evening, everyone. Welcome to all of you for joining our Facebook live session in this lovely evening. I need to mute the, yeah. Hi, good evening, everyone. Welcome to all of you for joining our Facebook live session in this lovely evening. My name is Yap from Bagan Specialist Center Marketing Team, and I will be your host for this evening. Today, I'm glad to invite Dr. Anil Krishna from Bagan Specialist Center to give us a sharing on the topic about labor and pain. Dr. Anil is our obstetrician, gynecologist, and urogynecologist in Bagan Specialist Center. If you have any question to ask our doctor, please feel free to leave the question in the comment section below, and Dr. Anil will answer the question at the end of this live session. To kick off the program, please welcome our speaker, Dr. Anil. Thank you.
Hello. Yes. Good evening, ladies and gentlemen. Okay. Today we will. This is the second session, part 2 of the initial one, which I talk about antenatal care. So after the antenatal care, we continue with labor. So today I'll be sharing about labor and pain. Okay, let me just. Okay. Okay.
I need to share your screen.
Okay. Okay. Okay, we shall start. So today my topic is for this evening is labor and pain. Okay, labor and pain is like synonymous. It goes together. So first of all, please understand that labor is a physiological process. Okay, if physiological means it's a natural process. It is not something. It is not a disease, but it is just happens naturally. That is what I have to first message I want to tell everybody, and it is important to know that we are here to just assist you. The main work is done by the ladies actually. So first of all, labor, okay, you can go into labor by 2 ways. One is sometimes we do induction of labor, which I will explain, and sometimes it is spontaneous labor. Spontaneous labor is what happens naturally. So first of all, I will explain about induction of labor. Induction of labor is basically, by definition, it is a process of artificially stimulating the uterus to go into labor. Basically, we are forcing you to go into labor. Okay. Why do we do this? This one is done for many indications. Some of the indications are like if you're overdue. Okay. So normally pregnancy is the due date is you can see the LMP, which is the last menstrual period, and the EDD. EDD is the due date, estimated due date. Once you go more than 1 week, say your due date is on the 1st, and suddenly until the 8th, you're still not delivered. So it's already 1 week. So we will reassess, and we may have to force you to go into labor, because studies have shown that there are more risks if you go beyond 41 weeks. Other conditions where we force the labor is if a lady has medical problems. The two most commonest medical problems in pregnancy are diabetes and hypertension. Diabetes and high blood pressure. Okay, so diabetes depends. Sometimes diabetes, those who are on medication or insulin, usually we try to induce at about 38 weeks. But those who are not on medication, those who are just on diet control, we do that at about 40 weeks. And those with high blood pressure also depends how good is the control. Basically, if the control is good on medication also, we induce at about 38 weeks. Otherwise, we see the situation, and if its situation is not very well controlled, we may induce earlier. Also, another common complaint is when baby movement are reduced. Okay, some people during the delivery time, the baby movement are reduced for various reasons. We also sometimes don't know why, and if we don't feel comfortable, we may just induce. Or sometimes some women, when we do the scan, the amniotic fluid, the amount of water in the abdomen, in the uterus, the level goes low for some reason, or if the water bag breaks prematurely, before the pain, before the due date, then we induce. And there are many other indications. Sometimes some people just request to induce. So there are many indications for induction. So how is this performed? First, the obstetrician will do a vaginal examination and assess the cervix. Okay, cervix is where is the lower end of the uterus, where it has to open for the baby to come out. Okay, so this is how we do a vaginal examination. We use 2 fingers and assess the cervix. We see the length of the cervix, whether it is open or not, whether it is soft or not, position, and all those kind of things. Okay, from this assessment, we know how we roughly can judge whether the induction is going to be successful or it may take a long time, or how we want to induce. Okay, how we want to induce. These are basically, sometimes we insert tablets. I explain. So once after we do the assessment, then we decide. Basically, induction, commonly we use 2 methods. One is we insert a tablet, okay, which is left there for like 6 hours, and hopefully the cervix, it becomes thinner and pain starts. Or sometimes we insert a medication, IV medication. Okay, this kind of thing. We put a needle into the vein, okay, to give medication intravenously, and we use some medication to start the uterus to contract. And once the cervix is open, what we do is we rupture the water bag. Okay, so this medication is given IV. Okay, the medication is inside here, is in drip, and it is controlled. We cannot give too much. We titrate it accordingly. Okay, that means we give at a certain dosage to increase the frequency of the contraction. And also we usually rupture the water bag. Okay, this one also done vaginally. Once it is open, the cervix is open, we rupture. So to see, this is to hasten the process of labor. Okay, that's the idea. So once we rupture the water bag, it can go faster. That is about induction. Spontaneous labor is what most people experience. Suddenly they feel the pain. Okay, so what are the symptoms of early labor? There are some non-specific symptoms, like sometimes they have low backache. They have pain in the back or pain in the front part of the abdomen. They have some pain, or sometimes they have this decrease in the baby movement. Okay, suddenly they feel that the baby is moving less. Okay, one of my theory is because once the uterus start contracting, once the contraction start, sometimes the baby get, they're like, what's happening? So they suddenly they terkejut, so that's why the movement starts reducing. Or some people may experience some abdominal cramps or diarrhea. Okay, diarrhea also quite common. That is because of those chemicals released from the cervix. The chemicals cause diarrhea. These are the early symptoms. So basically, symptoms of labor, general symptoms of labor, number one is show. Okay, show is basically a mucus plug mixed with blood or brownish, which a lady might pass. Okay, so the mucus plug comes from the cervix. Okay, as you can see in the diagram. Okay, this is the cervix. It has opened slightly, and these are all the secretions and the mucus secretion. It is released through the vagina. So it looks something like this, some sticky, reddish, brownish material. Okay, this is one early symptoms. And sometimes they might have rupture of the water bag. Okay, sudden gush of fluid. Okay, sudden gush of fluid. Suddenly they're doing some work. Suddenly the undergarment or whatever they're using feels very wet. But so when you feel something like this, you are advised to come to the hospital to check. But sometimes it can be a false alarm. Okay, sometimes it can be just urine. It is quite common in pregnancy. The sudden gush of fluid might be just urine. So whatever it is, urine, or if the water bag has ruptured, please come and check. Okay. Then the other symptoms, the most important is the labor pains or the contractions, which cause the labor pains. So sometimes these ladies, they will come to hospital and say they're experiencing pain, but it may be false labor pains, that is low backache or some mild pain abdomen. Okay, true labor pains, how a true labor pain is described, it is a regular and increasing pain or contractions of the uterus. That means when initially you may experience the pain, maybe very mild, still can tahan, and suddenly you feel that it is increasing. Maybe initially it comes every like half an hour once, then maybe every 15 minutes once, then it increases, and the pain also increases in intensity. You feel more painful, and it's getting more frequent. Okay, so when it gets more frequent, when it starts increasing in pain, if you're staying near the hospital, time to come to the hospital and check with us. Okay, and this pain, it starts from the top. It's called the fundus, the top part of the uterus. Okay, not from the down. You feel when you put your hand on top, that part is you feel hard. Okay, it starts from there, and this is very important. The pain, why it starts from the front or from the top, it is to push the baby down. Okay, to push the head down, to push it down and open up the birth canal. So as you can see here, the pain starts from the fundus of the uterus. Okay, this is called the top part of the uterus. It's called the fundus of the uterus. Usually the pain starts from there, and it pushes down. So you can feel when you put your hand, you can feel this part getting hard. It gets hard and then it softens back. It gets hard and softens back. That's the process. Stages of labor. So basically, there are 3 stages of labor. There's the first stage, second stage, and the third stage. The first stage is the latent phase. Okay, it is just mild pain only. Okay, just not very painful. Then there's the active phase. Active phase is first stage. There's active latent phase, active phase. Active phase is when the pain increases. Okay, pain is more frequent. And then there's the second stage. Okay, second stage is from first stage is from the time the pain starts until the cervix, the canal is fully open. Then the second stage is the delivery of the baby, and the third stage is the delivery of the placenta. Okay. So once you have the symptoms, okay, don't panic. Okay, don't panic. Once this we have a checklist. Okay, you can't see in the slide. Later I will share the checklist. We will tell our marketing team there's a checklist, and then you can come to Bagan. Okay, the checklist is to prepare okay, to prepare all the things before you have the pain. So around, once you're around 36 weeks, 37 weeks, the doctor says that it is for you, it may be time to deliver. So you can prepare the things so that you don't panic. And then once the day comes, once the time comes, you can come to Bagan. Okay, now let me explain about the first stage. Okay, the first stage of labor, which is the start of the pain until the opening of the birth canal, is divided into the latent phase. Okay, the latent phase is just mild pain only, just a bit of mild pain. It can last about 18 hours. Sometimes it can last 18 hours, but it is very variable. Some people it can last longer, some people it is less. So it is very variable. So this one is, they have just mild contractions, maybe one contraction in every like 20 minutes, 15 minutes, those kind of things, or 10 minutes, but very, not very strong. And when we check the cervix, when we do the vaginal examination, the dilatation is less than 4 cm. That means the opening is less than, usually about, sometimes it's not open, or sometimes it's like 1 or 2 cm. It all depends. And the cervix is maybe still thick. So this one is the latent phase. So once things kick in, the active phase kick in, that's where the action starts. Okay, that's where the action starts. Usually contraction is, that's where the action starts. And then there are regular contractions, 3 in 10, moderate. Okay, that is the active phase. In active phase, we want 3 to 4 contractions in the 10 minutes. Okay, so usually when the nurses check, they will tell us, oh, doctor, 3 to 10 contractions, or 4 in 10 contractions, and then lasting how long? If it's more than 30 seconds, 45 seconds, that means it is already in the active phase and strong contractions. So this is very important. Okay, the reason why we need a strong contractions is, as I said, to push down the baby's head. You can see here, the baby's head gets going down. This is the descent. Okay, head goes down, and as the baby's head goes down, it push on the canal, on the cervix. The cervix is about 2.5 centimeter. From 2.5 centimeter, it becomes paper thin. Okay, that is called the effacement, the thinning of the cervix. It will be completely effaced, and then only the opening, the dilatation, the opening of the cervix. The cervix open from 0 to 10 centimeters. Okay, 10 centimeters for the baby to deliver. Okay, then once it is nicely descended, once the baby is nicely deep in and the cervix is open, it's called full dilatation. It's already full. Okay, as you can see here. So the baby's head from here, it goes down through the canal and it descends, and while it descends, it opens up this canal for it to come out. Okay, so that is all about first stage. So what do we do during first stage? So one thing is, once the cervix is a bit thin, and once it is like 3 to 4 centimeter, what we do is we rupture the membranes. Okay, we break the water bag. Okay, as you can see, we use this kind of hook. This hook is to a plastic hook to break the water bag. Okay, so once this is about 3 to 4 centimeters, we start breaking it. Sometimes some ladies come in 5 centimeters, 6, and also depends which stage of labor. But whatever you do, it is to break the water bag. So we break this for few reasons. Number one is to hasten the delivery, for the delivery to go faster, and then and also to see, sometimes we have to see the color of the amniotic fluid. Okay, so if the baby is distressed or anything like that, and if the baby pass motion, the color won't be clear. It will be around, it's like greenish in color. Okay, so so that is the reason why we rupture the water bag. Okay, so besides that, once we rupture, we chart the pantograph. Pantograph is a graph kind of thing, okay, to see the progress of labor. Then we monitor all the vital signs. We monitor the mother's the blood pressure, and all that, pain, and then the hydration, and then we also monitor see how the cervix is opening. We also monitor the baby during this time. We do the CTG. All this I will show you, explain to you. And also we have to make sure there is regular and strong contraction. Okay, this one sometimes we add some medication to hasten the delivery. And pain relief. So this is the pantograph. Okay, a pantograph is a pictorial representation of the labor. So as you can see here, we will chart this thing. Okay, as the labor progresses, as the open cervix dilates, as the cervix opens, we will chart this. Okay, all the information about the mother and the progress of the pregnancy is in this one sheet of paper. So when we see this, we know, okay, if the labor is progressing well. If the labor is not progressing well, once it crosses certain threshold, then we have no choice but to do a cesarean section or do some intervention. Okay, so everything is shown in this one piece of paper. CTG, cardiothoracic. This is the sound, the tuk 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 tuk, the heartbeat sound. Okay, this is every labor room you will hear this sound. Okay, this is the heartbeat of the baby. Okay, so CTG, what we monitor is, you can see here, there's two lines, two markings. This one is the baby's heart rate. Okay, so we make sure it is between like 120 to 160. Okay, we don't want to see any variation beyond that one. Okay, and the second line is the contractions. Okay, so there are two kind of transducer they put. One is to measure the baby's heartbeat, and one is to measure the contractions. That means how many times the uterus is contracting. These are the two very important information we get from CTG or cardiothoracic. Okay, next is pain relief. This is the most important for me. This is very, very important in labor. We have few methods of pain relief, okay, which I will explain. But before that, how does pain occur? Why pain occurs in labor? So during the first stage, it is because of the uterine contractions. The uterus is contracting. So what happens is, every time the uterus contracts, the muscles, the blood supply to the muscles become less. So that one causes less oxygen to the muscles. So that one accumulation of all some chemicals there, that causes the pain. Okay. So that is why you feel the pain during the contractions. And during the second stage, where the delivery part, okay, the fetus, the baby's head is going down, okay, and the stretching of all this perineum. When the head is going down and the stretching, okay, this part, all the muscle stretches. Okay, imagine a cannonball, 10 centimeter cannonball coming out through a narrow passage. Okay, all those muscle stretches and comes out. Oh, that is the most painful of the pain. Okay, I think we men cannot experience that. Okay, that is said to be the most painful thing. Okay, so basically we don't want women to experience all this lah. We try to reduce all this. So how do we do it? For pain management, there are few ways. There's called the non-pharmacological. That means not through any medication. Or pharmacological is we give some medication, pain control. So non-pharmacological, we sometimes do some psychological kind of thing. We give some psychological treatment. What we do is, those ladies, especially the first pregnancy ones, those who are not experienced what labor is, so usually we have some antenatal classes like this. Okay, and usually if like in the government, the health nurses will come and tell you what to expect, how the pain, how the symptoms, and all this. Okay, so all this you will be prepared. And then if there is pain, what we'll do. And also I myself advise, if some women, the pain threshold is very good, but some women the pain threshold might not be good. So we anticipate that and we advise them, okay, to maybe take epidural, advise them about epidural or other types of pain relief. That is one method. Another one is sometimes there certain places there are birth assistants or doula. A birth assistant basically a lady who sits next to the mother who is in labor and just TLC lah, hold the hand, make sure she's hydrated well, give some sweets or what, make sure she's comfortable. If she's anything can so that the lady doesn't panic lah. Basically something like that. Okay, so this lady keeps the mother comfortable. Or sometimes we let the husband in, but this one also controversial. Some ladies don't want the husband in. Sometimes the husband cannot take the blood. Now we've seen all kinds of things. So in our labor room, we allow husbands in. Okay, we encourage the husbands to be beside the wife. Okay, this also sometimes helps the ladies. Then there's a position. Unfortunately, we have in our place we have only one position, but certain places they have different type of position. Okay, sometimes they do some touch, some massage, some funny things. Okay, then certain places they have this water bath. Water bath? During labor they use warm water. It is like with aromatherapy and all that. Okay, so this one also is said to warm water, supposed to calm the lady down and supposed to make the labor progress well. Sometimes this one all we cannot do lah. Sometimes whole family also goes in. Okay, so that is all the non-medical, not pharmacological methods. Pharmacological medication, what we practice here, we give medication. Okay, we give injection or we give gas or give epidural. Injection, basically what we commonly give is two types, either pethidine. Pethidine is like an opioid. Okay, this one give intramuscular, inject into the muscle. So this one usually after giving this, it helps. Okay, it helps in reducing pain, but sometimes they might have, and also it causes sometimes giddiness. They feel sleepy. Sometimes I feel happy also after this giving this, they'll go to sleep. So they are more relaxed, labor progress well. But some side effects must come to us, some vomiting will be there, these kind of things. So there's another thing, this one usually given in government hospitals and certain hospitals. This one has less side, it's something like pethidine, but less side effects. Then there's this Entonox. Entonox is basically gas. Okay, Entonox is gas. It's a mixture of nitrogen and oxygen, 50-50. Okay, and this one the lady holds it. Okay, or sometimes with the husband or somebody there, we teach them how to hold the thing. And once the contraction starts, once the pain starts, you ask them to inhale the Entonox. So it depends on the device. Certain people, certain hospitals, there's the mask type. Certain one you have to put in the mouth and inhale. So there are different devices, but the gas is the same. So this one also the efficacy is variable. Okay, some people are pain is relief with this, but some people might not be relief. Then epidural. To me, epidural is God's gift to women in labor. Okay, this is the best. This is the best. What is epidural anesthesia? Epidural anesthesia is basically regional anesthesia. That means it blocks that particular part of the pain. It doesn't like epidural is just half only. Okay, it's not like full body gets blocked. Okay, so it's a type of regional anesthesia, just certain part of the body. In this case, the contractions. So what is the goal? The goal of epidural is to provide pain relief. Okay, to provide pain relief when in labor. It doesn't cut out all your body movement all, no. Okay, the leg maybe feel a bit numb, but main thing is maybe your sensations will be reduced lah. Maybe where the part where it is where the thing acts, the pain will be reduced, and sometimes the sensation you won't feel the cold, the warmth or the cold, that kind of thing. And what it does is this epidural, it blocks the nerve impulses from the lower spine segment lah, okay. And this results in decreased sensation, so the pain reduced. So advantages is it allows labor to progress well. Okay. Pain relief, pain relief is very important because the reason why is, for me, once the mother is not in severe pain, she's relaxed. So once she's relaxed, the labor will progress well. So that's the importance of pain relief. If the mother is in pain and is very painful, then she goes into distress. Okay, she goes into distress and the body releases certain chemicals, which once the lady is in distress, the labor will not progress well, and then end up in the labor room for many hours, and then finally end up in cesarean section. So pain relief is very, very important during labor. So that is why reason epidural anesthesia is most of the time it works very well. Sometimes occasionally some people, they may have some pain one side of the leg may feel, one side will not feel. All that all depends individual, but pain is reduced significantly. So when pain is reduced, there is a positive birth experience. Okay, mother feels happy during delivery. And also another thing is after delivery also, when we suture the episiotomy, mother is more relaxed. But the other side effect is suddenly there might be a drop in blood pressure. Sometimes after putting the epidural, the blood pressure drops and suddenly the baby's heart rate goes haywire. Okay, so sometimes this can happen. So what we do is before giving the epidural, we make sure we load with fluid. We at least half a liter of fluid we load first. Okay, so hopefully there's no sudden drop. And another thing is sometimes the mother might not feel the urge to push, so it takes a longer time to deliver, and we may end up with instrumental delivery, either vacuum or forceps delivery. So epidural anesthesia, okay, it is done by the anesthetist. What he feels for the backbone, okay, he will give something to numb the skin here, and then he will inject. Okay, there's a special needle. He will inject into the epidural space. Okay, epidural space, as you can see, the spinal cord, it has 3 layers. It doesn't go all the way in. It just goes into just outside the second layer. So they will put the needle in, and then they will put a tube. Okay, they will put a tube inside. This tube is to inject the medication in. Okay. So this is the experience, real life experience. Once before epidural, it's all in distress, pain, and all that, and then after that, it's all full smiling. Okay, so when the mother is smiling, I'm also very happy. Okay. So first stage, start of pain. Okay, start of the pain, start of the contractions, and then start of the dilatation until the full dilatation. Okay, the head is down, the cervix is fully dilated, 10 cm. Okay, when we do the vagina examination, we can feel the head in the vagina already about to come out. That is the first stage. Now we are entering the second stage. Okay, what happens second stage? Second stage is delivery of the baby. So again, cervical os is fully dilated. The canal is fully dilated, and usually the nurses will encourage. Okay, that's when the team comes lah. Okay, all our team will be there. At least 2 or 3 nurses. Sometimes in government hospital, sometimes there can be many people there to encourage you to push. Okay, this is time. Once it is full, we encourage you to push. Okay, that is the teran, all that come. So before any intervention, we allow all this pushing business all for at least 1 hour lah. Okay, and during that time also we monitor the baby's heart rate. Okay, if there's any change in heart rate, anything we feel that we need to do any intervention, we will go ahead and do the intervention. So once you can see the head, okay, it's called crowning. You can see you can see the head, we do this episiotomy. So what is episiotomy? Episiotomy is basically we make a cut. Okay, this is the opening. This is the vaginal opening. Okay, we make a cut on the skin and the muscles here to facilitate the baby to come out. Okay, this is the reason. Sometimes the opening may be small. Sometimes the baby may be big. Okay, or sometimes when we have to do like instrumental delivery, if we have to use a forceps or vacuum or anything like that, we do the episiotomy first. Okay, but it is not compulsory for everyone to undergo the episiotomy, but this is done. Episiotomy is basically done so that if there's any, we make a cut so that if we don't do, and if there's tears, the tears can be very, the edges can be very jagged and ragged, and it is difficult to stitch. So that is the reason why we do this, basically to make the canal bigger, easier to deliver, and we don't want any complications. So this video,
episiotomy may be done to help speed up delivery if your labor is going too slowly, or if you or the baby are in distress.
So you can see from this video,
if you have not already received anesthesia
inject
before
some local anesthesia,
your doctor will inject medication to numb your vaginal opening and perineum, which is the area separating the vagina and anus. Using surgical scissors, a mediolateral incision is made on an angle from the vagina in the direction of the anus.
Area at an angle.
The benefit of the mediolateral incision is that it is less likely to tear through to
so
the
the skin and the muscle in the vagina, skin and muscles
it can also be more painful and take longer to heal. Once your doctor delivers your baby and the placenta, he or she will close the episiotomy incision with stitches. These stitches will be absorbed by your body and do not need to be removed.
So in case the second stage get prolonged, that means after 1 hour, sometimes 1.5 hours, pushing, everybody is screaming, taran, everybody gets tired, mother gets tired, or sometimes if the baby, the heart rate goes haywire, heart rate starts coming down below a certain heart rate, we have to do intervention. We use either the forceps or the vacuum. Okay, most commonly I prefer to use the vacuum to help the mother to take out the baby. Or certain medical conditions, certain heart disease, if the mother has certain medical conditions which doesn't allow her to push, then we have to use the forceps. Basically like those with heart disease and all that, we use the forceps to deliver the baby. And then after that comes the third stage. So once the baby is out, we clamp the cord. Okay, this is the placenta, this is the cord. What we do is we clamp. Okay, we clamp it. Okay, and cut it in between. Then we give the baby to the mother to hold. And then this part, we will remove some blood. This one to do the blood test later. And then we will slowly deliver the placenta out. Okay, there is a way of delivering. We control and pull. Okay, we don't pull it very hard, and we make sure the placenta is out. Okay, and once the baby is delivered, they may give you an injection. Okay, routinely given an injection for the uterus to contract. So that the bleeding reduces. So signs of third stage. There's some signs. Okay, after the delivery of the baby, then we wait for the placenta to come out. The sudden gush of blood, suddenly some bleeding will come out. Then the cord starts lengthening. Then you can see the uterus also contract. Okay, it looks like a ball. That is when all this that is when the placenta starts coming out. But occasionally, occasionally the placenta gets stuck. It doesn't come out like normal. So if it's stuck like not too in, maybe we can handle it in the labor room itself. Okay, we can give some Entonox, some gas and all that, put our hand in, gently remove the placenta. But if it's difficult, we may have to take into the operation theater, give full anesthesia and remove the placenta. Occasionally this happens, not very common, but occasionally. So after delivery, what we do is, after delivery of the placenta, we check the placenta, we make sure everything is there, all the placenta pieces all there, okay? And then make sure nothing is left inside the uterus, because if it's left inside, sometimes the uterus doesn't contract properly, starts bleeding. Then we check the perineum, where we did the cut, we check it, we see whether it is how is it, how deep is it, whether there any extended tear, and then we suture the episiotomy. And after that, we check the vagina and the rectum. We check everything properly, and then we put one finger inside the where the feces come out the rectum, and we see if everything is intact. So episiotomy repair, 3 layers. When we cut the vagina, we cut the muscle, this muscle here, perineal muscles, and the skin. So when we suture back the vagina, we suture back the muscles, and then we suture back the skin. Okay, this is what we, this is how we suture back. Then care after delivery. Okay, most important is get enough rest, have a diet rich in iron, calcium, take enough fruits and fiber, make sure bowel movement is good, okay? And still your bowel movement will be, you might be still constipated, so take enough fluids, take enough fiber to fluids to get hydrated, fiber for bowel movement, try to move around. And also I will advise everyone to do the sitz bath. Sitz bath, basically you take a basin, you put a warm to hot water, take 2 tablespoons of fine salt, okay, dilute it, and then you sit inside there, okay, just rendam the wound there, do it at least about 3 times a day. Okay, so this basically this warm water, what happens is the blood flow will be there, it encourages healing, and those who have, like sometimes they get badly infected or something, also I give this treatment, it cleans back the wounds. So this is, for me, this is very important. Next is cesarean section. What if you cannot deliver normal? Okay, so you have to go for cesarean section. Just in case, for many indication, suddenly the baby's heartbeat go haywire, or after like some 10 hours, when we rupture the membrane, it's 3 cm. After 10 hours, it just progress 2 cm to 5 cm. The head doesn't come down. Then we cannot wait any longer. We have to deliver through the abdomen. So we do an emergency Caesar. So sometimes we do elective for some other reasons. So we have many indications for Caesar. So the procedure is we put the mother under anesthesia. The anesthetist do it. Depends what type of anesthesia, half or full. Spinal is half, and general is full. We clean the abdomen and all that. Then we cut the abdomen, cut all the layers. Okay, uterus is delivered. The uterus is cut. Baby delivered. Okay, then the cord cut and all that, placenta delivered, check everything, close back. Basically open the abdomen, deliver baby, placenta, close back everything. So you can see here, okay, this is a short video. So once the baby cannot come out through the vagina, come out through the abdomen. So mother under anesthesia already, we clean all this. Basically we will cut an incision sideways like this. Most of the time we cut this one. Make an incision about 10 centimeters. We cut all the layers. Baby is delivered. Baby delivered, placenta delivered, then we suture back everything. Okay, that is cesarean section. So as a summary, labor is physiological. Okay, labor is physiological. It is not a disease or anything. You must remember that it's a natural process. There are 3 stages. First stage is from the time the pain starts until the cervix is fully dilated. Okay. Then second stage, baby come out. Third stage, placenta come out. Okay. Sometimes they say a 4th stage, that is the part of the healing after all this when you go back. So you have to basically, those who are expecting, please know the symptoms. Okay, please have a checklist. Keep everything ready when the time comes. Pain relief important. Okay, please consider on the pain relief. Certain places they offer the epidural. If you don't have, if you can, it is good if you have a good pain tolerance, no. But those who don't want to experience pain, epidural is very safe. And also, please remember that not all labor can progress smoothly. sometimes things happen and may need to do a Caesar. Okay, the cesarean section rate depends on places. I think here is around certain places is about 15. Here is around 15 to 25%. Okay, the cesarean section rate. So finally, if you have any questions, if you want to know any details, I think there are a few questions. Any details, please contact me. Okay, you can go to my Facebook page. Okay, can WhatsApp me from my Facebook page. Okay, there are a few questions. Okay, then okay, please like my page. Okay, there is one question. Does thyroid, TSH low, T3 and T4 will affect the pregnant woman or prepare pregnant woman? If got this kind of symptoms, can women get pregnant? Okay, so basically, medical disorders, all of these medical disorders, thyroid problem or diabetes, those who have medical problem, what we suggest is, it's not that they cannot get pregnant or anything. What we suggest is, before pregnancy, if you're planning the pregnancy, before pregnancy, try to control it. Okay, get it sorted out. Okay, like thyroid, you see the endocrinologist, get it optimized, make the levels all, try to make it as normal as possible before you get pregnant. Or if you're pregnant, what we do is we intervene early. Okay, we may give medications, sometimes the dosage also varies, or we refer to the expert, the endocrinologist, to optimize the situation first. Same thing like other diseases also, like diabetes also. Diabetes we can manage, or high blood pressure or any other medical problems. Okay. So first is we prepare the woman, optimize pre-pregnancy, before pregnancy, or during pregnancy we try to optimize also, and then we manage accordingly. Okay. So it's not to say that they cannot get pregnant or they cannot deliver or anything like that. We optimize the situation and then we will advise you accordingly, and we can carry on with the pregnancy. Any other questions? Okay. So there's only one question. So thank you very much. Thank you very much for listening to my talk on labor and pain. Okay. If you have any other questions, can you can ask questions through the Facebook, or you can contact me. Thank you very much and good night. Okay.
Dr. Anil. Dr. Anil, can mute your... I want to do the ending.
Is it?
Thank you, Dr. Anil, for the sharing. And with that, end our live session for this evening. Thank you for joining in this live session and hope you all have a wonderful evening. Thank you.
Right.